Let's take a look at hand fracture surgery. The hand is very susceptible to injuries from direct blows to crush injuries to torquing injuries to falling on an outstretched hand. Let's look at some of the common ones though. This is a martial artist. Proper punching is key, but frequently martial artists and boxers and those of us that maybe have a little anger management issue and go out and strike a wall occasionally are susceptible to improper technique and can get fractures of the hand. Also crush injuries. Let's look at the carpenter here. Just hammering nail after nail can slip, causing a crush injury, particularly to the tip of the finger. Now let's look at the anatomy that's involved with finger fractures. First, we need to look at the bones of the hand. Where are they? Well, the fingers are made up of phalanges, and there's 3 phalanges, distal, middle, and proximal phalanx of all the fingers. The thumb has just 2, the distal and the proximal phalanx. And then there are the metacarpal bones. The metacarpal bones are the bones that bridge between the knuckles and the wrist. And you can see there's 5 metacarpals, typically labeled 1 through 5, starting with the thumb, index, middle, ring, and little fingers. So let's take a look actually now at the actual fracture patterns. They're the metacarpal fractures. They can be transverse in orientation, just straight across. They can be oblique or more of a spiral fracture where they kind of wrap around the bone, or they can be, again, a short oblique. And the oblique fractures typically are inherently unstable because the forces across the fracture typically displace this, so they're usually highly unstable. Now let's take a look at actual metacarpal, it's called a boxer's fracture, which is a metacarpal neck fracture. This again is from improper punching, striking a wall or another human's head, and what happens is the knuckle, when it breaks, it's out right near the joint, and again, fractures displaced because the muscles and tendons pull them in a direction they shouldn't be going. So the typical tendency is for that bone or the head of the metacarpal to go in a palmward direction, and these typically we can, in most cases, we accept a lot of angulation because fixing these fractures would typically cause more stiffness than not. So we'll accept up to 70 degrees of angulation with these, but in some, as you'll see in a minute, you actually have to put some pins in. Now let's take a look now at typical fracture patterns in the fingers. On the top left is called a tuft fracture, the distal phalanx. And this again occurs usually from a blow from a hammer or a crush injury, and usually can rip apart the nail and the skin, and the bone actually can protrude through the skin and needs to be repaired right away, many times in the emergency room, by simply sewing back the nail bed and placing in a splint. Sometimes these do need internal fixation, as we'll see in a minute. On the bottom left, this is a proximal phalanx fracture called an oblique fracture because it's on a bevel. And again, from the deforming forces from the tendons, typically angulate or displace and need to be fixed. Up here, the middle phalanx. Again, this is a transverse fracture, but the tendons that extend and bend and flex the finger typically pull this in different directions, again, leading to an unacceptable alignment. And finally, an oblique fracture of the proximal phalanx out towards the head. You can see it's on the angle, and again, is displacing. So these the fractures we're talking about today are ones that typically need to have surgical repair or internal fixation. Now let's take a look at clinically what we look at. Obviously, if the bone comes to the skin, we see that, and we see deformity if the finger is crooked. But one telltale sign that's very important on fractures is to look at the finger alignment. The finger should bend down towards the base of the thumb here, all in unison. The little finger a little bit under the ring finger, but basically are all in unison. When you break a bone, the metacarpal or the phalanges, the bone can twist. And it can lead to what we call a rotational deformity of the finger. This is 101 fracture treatment, and that must be properly aligned. So it's one of the first things we'll do is even though it's broken, we'll have you bend a little bit so we can gauge if there's rotational malalignment. So take a look at the little finger here. You can see it underlapping or overlapping the adjacent fingers. So this can be very debilitating with use of the hand. Let's look at this in an actual individual. This gentleman was a musician. He had broken his finger, didn't get medical treatment right away for the first couple months. It healed in this crooked position. But look at the significant deformity here, all from a break right here. So we had to go back in his case, re-break the bone, reposition it, put a plate and screws in to correct that. Because as a musician, he had a lot of problems with this deformity. Now let's take a look now at some before and afters. But before we do that, just to show you some typical fixation. We'll talk about two predominant fixation. One is just percutaneous, putting a wire through the skin to hold the fracture in place, which is done under a special fluoro or real-time imaging that we use in surgery to see where the pin is going and to make sure the bone is properly aligned. But in some fractures, those ones where they're typically long oblique fractures that are very, very unstable, we'll actually have to cut open the patient and put some screws in place. The problem with that is the more cutting you do, the more the scarring and overall rehab time and potential for other surgeries to release adhesions. So now let's look at some before and afters. This next is a CAT scan of an individual who struck a heavy bag in boxing so hard that he dislocated the third, fourth, and fifth metacarpals. This is a CAT scan showing what we call fracture dislocation. So the base of the third metacarpal here where the arrow is, you can see the fracture goes into the joint, but the whole joint is dislocating. So all three of those joints at the base of the middle ring and little fingers were dislocated or shifting out of place. So we had to go in and put those back in place. So let's look at the after effect. Look at all the pins, but here are the three joints down here that were all popped out of place, and we went in and placed these back in place with an incision because we had to open and put these back in perfectly, and then we secured these with multiple pins. About 5 weeks later, 5 to 6 weeks later, typical healing time, little minor surgery to take the pins out, and then started rehab. Now let's take a look now at a thumb metacarpal fracture. This is a fracture usually from a jamming or torquing injury to the thumb. And you can see the base of the metacarpal here, and because of all the muscles that are bending the thumb and pulling the thumb in different directions, this bone tends to angulate. So in this individual, we went in, put the bone back in place without having to cut open the patient and putting a couple pins across. So let's look at the after x-ray here. You can see good alignment. Now it's straight, not crooked. 2 pins across again for about 5 weeks, and those come out and start therapy. Now, let's take a look at we had talked to you earlier about that boxer's fracture. Typically, we accept a lot of angulation, but one time that we do fix these is if the bone is completely separated. Look at the shifting of the head of the bone down here in relation to the shaft of the bone. It's completely knocked off, as we say. So in this individual, we went in, put it back in place again without having to cut open, and then shot a couple pins across, as you can see in the next x-ray right here. You can see 2 pins going across the 5th metacarpal head into the 4th metacarpal head, just anchoring that back in place. Then the pins come out, and again, more rehab. So let's take a look now at another fracture. This is an individual that was in a motor vehicle accident, and he sustained fractures of the 3rd, 4th, and then over at the base of the little finger towards the head, another fracture, but that was non-displaced. It's really the third and 4th metacarpals here had shortened, and the patient had rotation of the fingers. So again, in this case, we had to go in and put some screws in and do it through a small incision on the back of the hand, and we move the tendons out of the way. And then we go and put 2 screws in. Let's take a look at the next x-ray. You can see 2 screws here and 2 screws here. We lag those in, so as we tighten them up, that bone compresses, and you can see much better alignment now, the preservation of the length of the bone, and clinically he had no rotation of his fingers like we showed in that individual earlier. Now, the next fracture we're going to look at is a 5th metacarpal fracture. Again, just to show you more of the same really, but to show you different fracture patterns. This is long oblique fracture with the pulling of the tendons tends to shift the finger in this direction. So in this individual, again, went in, cut him open, put 2 screws in. Let's take a look. So we put the screws in from 2 different angles, going in 2 different directions to compress that fracture with from the best position possible. Now, another fracture we're going to look at this is in a professional snowboarder who qualified for the Olympics. Before doing so, though, she had a horrific accident where she fell, sustaining a fracture of the index or the 2nd metacarpal. This is a CAT scan here, and you can accept very little angulation of the fractures as we go into the index and middle fingers as opposed to the ring and little finger metacarpals. So this is unacceptable angulation, several pieces, and we went in and put a plate and screws, as you can see on the next x-ray, right along the back side or dorsal side of the metacarpal, and she did great, returned to professional snowboarding. Now, the next fracture we're going to look at is a school teacher that had her little finger pulled in an outward direction. Looks very painful, and it was. Look at the displacement of the fracture right here, and she came in with her finger literally pointing almost 90 degrees to the outside. So in this individual, these are great for just putting in percutaneous pins without having to do any cutting. So we take her to surgery, put her to sleep, push that back in place under that special fluoro imaging device, and then shoot 2 pins across, as you can see here, crisscrossing. These are intraoperative x-rays. You can see crisscross, the normal alignment of the finger, and she did very well from this. Now, let's look further into finger fractures. Look at this great image right here showing this significant fracture of the index proximal phalanx, and the fracture extends into the joint, but this was not separated, so we were actually lucky in not having joint involvement. Went in, cut her open on the back of the proximal phalanx, split the tendon, and then put 2 screws. Let's look at the after effect here. You can see 2 screws right here compressing the fracture with anatomic alignment, and these are low profile 1.5 millimeter titanium screws. So they're designed to stay in. Occasionally, if one loosens, you'll take it out, but usually that's all that's involved. Okay, so let's take a look now at this individual had a middle phalanx fracture from a jamming injury. Initially, she had a non-displaced fracture. So you ask your hand surgeon, why are you seeing me so often? Well, one reason is because if that hairline fracture, a non-displaced fracture, starts to shift, we want to catch it before it heals. So typically, you'll come in every 2 weeks, we'll get x-rays. So at about 3 to 4 weeks, she actually started to shift, and the finger started deviating, and it was deviating, as you can see, the ring finger towards the little finger over here. So we went in surgically, put her to sleep, put it back in place, no cutting actually, and just were able to put 3 pins in. Let's take a look at the pins here. We put one across the base of the tip of the bone here just to stabilize the joint, because that crack actually extended into the joint. So we didn't want to displace that and cause more of a problem. Then we crisscrossed 2 pins here, holding this in normal alignment. Now, pins came out about 5 weeks later. Let's take a look at the aftermath here. You can see right here where the previous pins were, which will heal in, but this is right after the pins were removed, and you can see normal alignment of the digit. Okay, so the one more fracture I want to look at. This is a base of the proximal phalanx fracture. This shows a good picture of the fracture going into the knuckle or into the articular surface. This is slightly separated, but in a very important joint like the metacarpal phalangeal joint or the knuckle, you need this as perfect as possible. And this individual had some separation here, but also had a rotational deformity. So we knew there were many reasons to look at doing surgery. The main one was a rotational abnormality, and then also there was some joint involvement. So we went in, made an incision, split the tendon, and then in this case, because there were a lot of little pieces, it was not amenable to putting those screws that could stay in. So in this case, we went in and put some wires. Let's take a look. We went in, this patient also had a rotational abnormality, so many reasons to fix this, but went in surgically, opened the joint up, put everything back in position, put several pins in because they were so many small pieces. The screws were not adequate for this, so we felt based on the fracture configuration, we put pins in, and these would stay in this individual about 6 weeks, and then to come out, and then he would need quite a bit of rehabilitation after that. So after these types of finger or hand fractures, usually there's a period of immobilization and usually a removable brace for about 4 to 6 weeks, then a minor trip to surgery if we put in pins to take those out. It's usually like a 5-minute outpatient procedure with a little local anesthetic, little IV sedation for your comfort. Once these pins come out or the fracture is healed, 4 to 6 weeks later, you're looking at up to 2 to 3 months of pretty intense rehab to get the movement back. But the fingers are so important to the function of the hand, you got to get there. For more on this condition and many other conditions, please check out our website.